Well, that wouldn't be me, probably.
So the raise, you indicated it would be for 2 of the products. How would that be split up between the 2?
First product will be our second lead at this point. Basically, what we have is drug product from the partner that would allow us to get into the clinic fairly quickly. And I think the lion's share of the initial raise would go to conducting those trials. We estimate it's around 2.5 million direct costs. Our lead compound, the 101 compound, will take longer to get API because it's basically, we're going to have to start and complete the manufacture. So we think that that will be completed in mid to late 2015, which is when this raise would require us to go out and get additional financing. And we're looking at probably about $2 or $3 million in terms of that, that particular piece. So, I think the goal here is that we've got 2 products that we can bring to fruition on the 10 million, where if there's a hiccup in each one or either one, then we can put resources on the other one, and it gives us a chance to build value. Because honestly, in this market, as you saw with Ironwood, we really only need to hit one of these to increase the enterprise value. If we hit both of them, then we are going to see some really quite amazing valuation. So, our strategy from the very beginning was to do some risk mitigation around that on these 2 phase 2 trials. And I guess the other point that I need to make is that these are not let's say all the phase 2 trials that we would need to do on these drugs. Those of you that have been around drug development would know immediately that 10 million is not really enough to do a phase 2 program. These are phase 2 bridge studies. In each case, we're bringing the best of the medical expertise to bear on conducting a study that will allow us to decide whether this compound is worth spending real money on in terms of a full phase 2, phase 3 program. And our goal is in fact to do that on both of them on the 10 million, so that at the end of that process, we're sitting around as medical directors and board of directors deciding which one is the one that we actually want to go raise the next round.
So the trials that have been done to date, where were they conducted?
All over the place. Our lead is actually on the market. There's a company called BioMarin that has it on the market in phenylketonuria. So there is a safety package available, and the chemistry is already resolved. The specific trials that have been done in gastroparesis were done at Stanford University for that one. For our second compound, it had a series of phase 2 trials that were done, multi-center trials that were done around the world. I think about 24 trials. It has been in 8 phase 2 programs for different indications. It's I guess the best way I can put it is it's an anti-inflammatory, so it's been used actually to try and treat a lot of different diseases. The one that showed up as being the most promising is Crohn's disease, but it's as an intravenous. So the initial developer, which is a company called Cytokine Biosciences, decided that they actually should develop an oral formulation, but they tried to do this at the beginning of the meltdown, as it were, the economic meltdown. So they really ran into trouble and were acquired by the European pharma. What we're acquiring are the rights to the oral formulation, and the thinking here is that it's got all the right pedigree from the multiple phase 2 trials that have been done already in terms of toxicology. That what we have to do, and this has been a big part of our conversation with the pharma, is we have to verify that it's got an efficacy signal as an oral formulation. We're quite confident of the safety because it's been through these other trials, and so I think without getting into the weeds here, the phase 2 bridge that we're proposing to do with the 10 million is a 8-week Bill Sanborn monitored study on this compound as an oral formulation to see if there's enough signal there to really warrant moving it into a larger program.
Would that be institutional IRB approved, or would that be an FDA approved
We would need
trial?
FDA IND.
So, I think a lot of the risk is with the number of regulatory assumptions you've made about being able to get 505(b)(2) status. A lot of
Right.
companies
Right.
believe they can do that. So, what can you just have go over what sort of interactions you've had with an agency that have indicated you can do what you want to do?
Right. That's a great question. I think, there are 2 points of risk here that you should all know about. One is the regulatory risk. There are some issues there, and I'll talk about that. The other one is the chemistry risk, and that is essentially to get an IND and to get into some of these trials, we must be able to manufacture the compounds to the specifications that we need to. So I can talk about both a little bit. The regulatory one, we have a consultant, Kurt Scribner, who is working here in the DC area, who's looked at all of these compounds and has worked with the gastrointestinal section of FDA. He is comfortable with what we're suggesting. I think the nature of our lead compound is such that because it's approved, we're fairly confident that we can get the 505(b) designation on that compound. Now, I think there is no certainty until that's actually done, but I think that's the indication that we're getting at the moment. On the chemistry side, we have a similar set of wrinkles, but our lead compound is a well-known compound. We have contacts now with companies in Asia and in Europe who manufacture the GMP product. So we're in the process of getting access to some of those sources of the compound. There's not really any chemistry issue there, it's mostly licensing and patenting. On the second compound, as I mentioned, there's about 1 kilogram of the active chemical or pharmaceutical ingredient available from the licensor. So we're quite confident we can get into non-clinical and clinical with that in the first year. And we now have been in touch with the manufacturer, the US-based manufacturer of that compound, to be able to get into subsequent trials if we acquire it. And then our third compound, of course, is still in formulation. So that one we'll be working with partners, and we have some of those partners in place to develop the formulation for that. But it's a fair way. It's probably 3 years away from an IND, so that's not a huge issue.
Time for one more question.
Okay.
So, a lot of what I hear, I think, as the story is that this is less risky than other investments through. Maybe you could just sort of walk through the de-risking strategy, if you will, sort of
Sure.
the key differentiators that would effectively say, our 10 million in you is going to go further, or
Yeah.
much
Right.
lower beta, lower risk than
Well,
someone else who has a portfolio of 3 compounds.
Right, and I think, Chris can certainly speak to this, but our strategy has always been to risk mitigate through basically 3 different strategies. One is to have multiple shots on goal, and to use these phase 2 bridge studies as a way to really call that in. I think it's folly to jump into a fully blown phase 2 program until you're absolutely certain that that's appropriate. But our strategy there is to just simply do a bridge study with the best expertise we can find to determine whether that asset is one we want to take forward. And I should point out, as part of this risk management strategy, we're negotiating with the licensors to take, to essentially send the product back if we don't like it. So, of course, we'll have to pay some option fees and things like that, but relative to the cost of doing development, that's pittance, So we've got them all to agree to allow us to hand the product back. So that's sort of leg 1. Leg 2 is that we have these 3 products. So if our lead fails for some reason, if we can't get the compound manufactured legally and within the thicket of patents to actually commercialize it, then we have a second and maybe a third on goal. So there's legal, marketing, chemistry, efficacy, safety, any number of reasons why one of these could fail, and I would expect one of the three to fail for one of those reasons. I mean, again, in terms of full disclosure, we don't expect to have all three on the market in 2022. My guess is one of them will crash for some reason. That almost always happens. But again, our strategy is if we lose one, we can put all our resources in another, and the company doesn't fail. And then I think the third leg that I want to leave you with is that if you look at the competitive drugs, or if you look at the companies that have been successful in this market, there are many drugs that are IV drugs that treat GI diseases, chronic GI diseases. Now just process this for a minute. If you have Crohn's and you're getting sicker, and the doctor says to you the only treatment is an IV, you have to show up at the hospital every 2 weeks and get plugged in for a day, versus taking an oral drug that acts on the inside of the gut at the exact location where the inflammation is occurring. That's what we're offering, is a much better safety profile, primarily because we're going after oral therapeutics designed for chronic use. You cannot tell me for a minute that IV drugs are designed for chronic use, but that's the truth. That's what's out there. So we're going after drugs that are specifically designed for chronic use, that are specifically designed to go to the site of action in the gut where the inflammation or the problem occurs, and to do this in a way that gives us the best possible safety profile. So those are really the methods of use.
So one more, if I may.
Sure.
Quickly. Talk a little bit about the relationship between what you're doing and broader demographic trends, whether it's global population, aging, et cetera, in terms of the potential implications, because I'm not familiar with sort of GI.
It's about a $30
opportunity
billion
over the next
it's about
20 years.
Right, it's about a $30 billion global market of prescription, about a $50 billion over the counter, including over the counter, and essentially, diabetic gastroparesis is known to occur in conjunction with diabetes, and we all know that the trend in diabetes is north. The estimates that I have are that about 15%, you can expect about 15% of diabetics to develop gastroparesis. So we're certainly expecting the market to grow in terms of those numbers. The inflammatory bowel disease, I think many of you have heard about, the microbial implications here. There are some companies that we're familiar with that are developing microbial supplements to help prevent inflammatory bowel disease. It's quite clear that there is an interaction between the environment and the immune system that leads to these diseases, and it's also quite clear that the numbers are going up in both Crohn's and ulcerative colitis. So, I think what we are seeing in our company is the ability to come into a growing market with drugs that are known to be designed for chronic use, that have the best possible chance of success in terms of safety versus efficacy. It's never certain, but at least we're trying to hedge the bets for what we're doing. And then do it inside a company or a corporate structure that allows for failure, because we're in an industry where we know that over 90% of drugs fail. So, why bet on one? I mean, that makes no sense if you're investing. So we're saying we're going to bring three in, where obviously if all three of them work, that would be great. But the expectation is that all we really need is one to work, to be very successful. And so that's the basis of the company.
Is there a big growing market in Greece?
Possibly, yes.
We have the Greek embassy here, so I'm sure they'll be interested.
Yes.
Great.
Thank you.